Hello and welcome from wherever in the world you are. We're delighted you've joined us for what we hope will be a very informative and inspiring discussion about innovative solutions to delivering palliative care in Africa, hosted by the Irish Global Health Network with the support of the African Palliative Care Association. While people are joining, it would be great if you could drop into the chat box which is down below, where you are joining us from. Let me introduce myself. I'm Jean Callanan, and I'm an advocate for dying well and a member of the advisory board of the African Palliative Care Association. I have just stepped down after 6 years as chair of Irish Hospice Foundation. I think, as many of you knew, we were due to be joined today in moderating by Dr. Eve Nasamgo, Executive Director of the African Palliative Care Association. Unfortunately, due to various flight cancellations, she is unable to join us today, so I'm afraid it's just me. I am delighted to have a very diverse group of contributors with us today, and we will be talking about innovative solutions to increasing the reach of palliative care in Africa, fundraising, communication about palliative care, and addressing audiences with specialist needs. I will be interviewing each contributor individually for 15 minutes about their innovations, and we will introduce each briefly before we start. And I think Ivana might also put a bio note into the chat so as you can see a little bit more about them. At the end of all the contributors, we will have an opportunity for your questions. So as we go, if you could please drop any questions or comments you have into the chat. We also will drop in some resources that we have so as you can use them. And if you have resources you think would be helpful for the participants, please feel free to drop them in. We want to make this session as interactive and as informative as possible, and we will keep to time, and we will have you out of here in an hour and 15 minutes. I'm not going to put an hour on it because of different time zones that so many of you are in. So we're going to start with an Irish paediatric oncologist who has lived and worked in Tanzania for the past 18 years. Dr. Trish Scanlon is founder and CEO of Tumani Lamasha, Their Lives Matter, a children's cancer initiative in Tanzania. She contributed to the last Irish Global Health Network webinar, where she told us all about the brilliant work of Tumani Lamasha in increasing the survival rates of children with cancer. So they have increased them from 1 in 10 children to 5 in 10 children, which is phenomenal. But sadly, 50% of those children are not making it, which means that they need palliative care support. And Dr. Trish and her team have developed innovative solutions for reaching out across Tanzania, which is a big country, to deliver this support. So that's what we want to talk about today. So, Dr. Trish, tell us about the national network of collaborators you're building across Tanzania.
Thanks a million, Jean. Yeah, it's one of probably the most exciting and important tools that we have. Basically, Tanzania is this huge, huge country. It's the size of Germany and France and maybe another country as well combined. And, a lot of care was just in 1 or 2, very experienced sites. But in order to, from a curative point of view, reach more children, but also from a palliative point of view, if a child did actually reach our service, but the treatment was not successful, we were so often just sending those children back to their homes thousands of kilometers away from us, and therefore we'd give them a bottle of morphine and kind of a blessing, and that was the best we could do. So what we're doing now instead is there are hospitals all over Tanzania, as in all of our all of countries all over the world. It's the same, right? But they don't necessarily all talk to each other. So that's what we have done with TLM is we have approached, we now have 22 hospitals in the network, and we approached each of them. We visited them. If they agree to be part of our network, they can choose one of three tracks, varying levels of treatment and participation. But it does mean that they can access services that we provide for free, and they can be curative services like diagnostics, transport, and treatment. And in the reverse, we can send children back to them and they can do follow up, including palliative care. And we will also support that. We do training for palliative care. We also give them access to medications. And we will register the child in the government health insurance so that even in their last days, it's that their access to the local services is covered by their health insurance card as well. So we do as much as we can to stay in contact with children. So 22 hospitals is not enough. We hope we will have 100, 200 hospitals in our network, so that they can, when they see a child early, they can, because obviously the best way of preventing a child from dying is and preventing the symptoms and signs of a child who's at that stage is to cure them. So getting them in early, and having access and a relationship with hospitals that see these children close to their home is the best way of doing that. But then on the other side, those hospitals can then take those children by the hand during those difficult days if the treatment doesn't work, and we can monitor that and help them and support them remotely.
You've been making great use of WhatsApp, Dr. Trish. Tell us about that.
Yeah, so we have a WhatsApp community, and what we do is we have trained locally. We have pediatric oncologists who've trained at the University Mumbili National Hospital, and they are in various hospitals around the country. And so we have regional groups where a larger hospital with maybe more specialists will lead the group, and then all the smaller hospitals can put in a clinical case, a radiology like an X-ray or a CT or an MRI, or just a difficult question, clinical question that they want help with, and so that we can remotely help like any site that's in our network anywhere in the country and pretty much instantaneous. So they get access to really high quality opinions free of charge and in real time when the child is in front of them. So it means that, when a country is as big as Tanzania, it's very difficult for sick children and families to transport children to a place where these opinions maybe are easier to come by. So the network, the WhatsApp network, allows them to have remote, almost like telemedicine, but just with WhatsApp, access to opinions right at the bedside in the small village or town hospitals.
It's a brilliant model, Dr. Trish. What lessons have you learnt in setting it up that you would uh, share with any of the participants who are looking at and going, oh, we could do that, or we could do a version of that?
Yeah, and I think everyone could do this. It doesn't cost any money and there's really goodwill. Everybody wants it because it actually saves time and it saves effort at the larger hospitals as well. If we can keep those children remote who can be managed remotely. I think one of the things that we have found is it's very important to develop, it's great all this remote stuff, but it's very important to develop a relationship. So we do go to the hospital, we do present, and we do explain kind of face to face. I think face to face is still very important to establish a relationship. But once that relationship is established, and once you've proven yourself, because if they put in a story or a question and we don't answer it in time, they won't put in another one. So it's really important if you offer in a commitment that you follow up on it and you are there when they need you.
Mm. You've recently started a palliative care network. Palliative care pathway. Can you tell us a little bit about that and how you're going to build on that?
Yeah, so basically what we're trying to do is we have found that for many diseases, many oncology diseases, chemotherapy, tablet chemotherapy, we call it metronomic chemotherapy. It's very simple, it's very gentle. It really, children can go about their lives quite well if they are on this, and it can extend their lives. These are for palliative children, can extend their lives from months to years. We have one child, oh, not one, we have a number of children who are on this treatment for up to 5 years, and we don't really know what to do to continue or stop. But we can't give it unless they're being followed up. And so what we have done is we have now appointed a palliative care patient navigator, and her job is really to make sure. So for our hospitals that are in the network, we have meetings and we follow up these children. But of course, there are still children going to other parts of the country that we haven't yet established a partnership with. So her main priority is to follow those children who we're still not sending home to a partner, and to make sure that they don't get into trouble, and that if they can take the tablets, or if it's just they need symptomatic control, that we're still remotely there for those children. And also to find that she then makes relationships with the hospitals that we don't have, to expand the network from a palliative point of view as well.
You have a partnership with a hospital or a university in Germany in relation to that?
Yeah, we do. We have actually multiple partnerships with universities and hospitals all over the world. I do have to say, CHI at Crumlin is one of our biggest partners. They don't necessarily aren't involved in palliative care, but they're one of our most biggest supporters. But yes, Tübingen University in the south of Germany, they have a very active palliative care program for oncology kids, and they have been helping us. We're setting up a little bit of research. It's not complex research. It's just looking at the types of things that we're missing and things that we should be adding clinically to those children, and setting up networks. We have an electronic medical record system as well that we've built that is live now in 9 of our hospitals, which means a child can move from one hospital to another, and you just add the hospital number to the child's previous record, and it unlocks all the previous data. So that allows the receiving hospitals to see what has happened, and it also allows us to follow them going forwards remotely. And so that's also a really important part of what we do. And yeah, so yeah, we're always looking for the next partner, whether it's an international partner or a local hospital. And I would also like to really stress, I know I am speaking and maybe the loudest person in TLM, but actually I'm the only non-Tanzanian in TLM who is a permanent member of staff. And so this is being led and moved forward by our amazing Tanzanian specialists. And I'm hoping in the next while that I'll become less vocal, and they'll be doing all this talking.
Mhm. I have to smile about you having your electronic patient system when, as you know, we here in Ireland are struggling to get such a thing. So it's wonderful to see you leading the way in that. Let me ask you as a final question about funding, because we're going to talk about funding a little bit more. Uh, Tell me about how you fund your operation, which is phenomenal.
Well, we're registered as a charity in Tanzania, in Ireland, and in the UK. I always say that I'm 20% doctor and 80% beggar, but actually we have a very active fundraising team in Tanzania. Again, all Tanzanians, and we do all sorts of things. We have some wonderful corporate donors. The Irish government gives us a large chunk of money. They're our biggest funder, and we're very grateful to them. We run events, and we have lots of people who are running and swimming and climbing mountains and cycling and doing all sorts of things. We recently had a group of people who paddleboarded across to Zanzibar for us. So there's all thing. We also have school children in Dar es Salaam. We have about up to 20 schools who basically the children they do tasks for a month, and they get the pocket money and they put it into a little box like a Troker box. In fact, it's exactly like a Troker box. We stole the idea, but they raise money for it. They raise up to $20,000 for us every year. So we kind of beg, borrow, and steal. We do as much as we possibly can to make everything free of charge to the children, both for cure and for palliation.
Mm. No, it's a phenomenal model, and I think one with there's an awful lot we can learn from. So thank you very much. And I think there are links if people would like to follow Dr. Trish's work or make a contribution, however small. There are links in the chat. So Dr. Trish, we're going to hold and thank you for now, and I'm sure there'll be questions when we come back towards the end. Uh, Fundraising, as we've heard, is always a challenge when it comes to palliative care, and nowhere more so than in Africa. So we want to talk next about a creative and innovative fundraising campaign for palliative care in Uganda, which has captured the imagination of people in both Uganda and Ireland, and has raised significant money. I'm delighted we're joined to talk about this by Mark Mswega, the Executive Director of the Palliative Care Association of Uganda, who are the partners of this Irish fundraising initiative. Hope on Wheels is the brainchild of Irish businessman Tom Doyle, with support from a small team, including Miriam Donoghue, who many of you will have seen on our last webinar when she talked about the legacy of her friend Dr. Anne Merriman. 11 ambulances were donated by the Irish Health Service Executive and the Irish Fire Service and were shipped to Mombasa. And then a team of volunteers, including TikTok sensation musician and comedian Garen Noon, drove the ambulances from Mombasa to Kampala, arriving in Kampala just last week, raising money and awareness both in Ireland and in Uganda. Mark, you're very welcome. I know you don't have a final amount yet, but can you give us a bit of a feel for what this initiative raised for palliative care in Uganda?
Yeah, thank you so much, Jean, and thank you so much for the kind introduction. And it's great to be on the call. And you have asked me a very good question about how much. And throughout this campaign, as we started, and as you have rightly said, that this is a partnership between the Hope on Wheels, who are in Ireland, the Palliative Care Association of Uganda here in Uganda, and of course the Ministry of Health. It's been more than money, I can say. It's been more than how much in terms of money do we need. And I know that we are still running. It's not the right time to say how much you've raised on this campaign. The last time I think I spoke to the team and noted it was about 120,000 euros, and it's going on up to the 30th of June. But let me share that specifically for this specific type of campaign, where ambulances of really modern type that have been mobilized and sent to Uganda, and the amount of money I'm talking about does not include the cost of these ambulances, does not include the cost of how much the publicity and the media has gone to this. And the amount of money that you can talk about does not include into the hope that you can see on the faces of patients, on children, on mothers, on people when we are talking about this program. So the time is going to come when we say the exact amount of resources that we have really received. But I wanted to also add on that one of the challenges that we face as Uganda, as Africa, as we look at palliative care, and this is the challenge that we always put forward, is how to correct as much as possible, how to raise as much as much money. But drawing from our inspiration for this campaign, who is Dr. Anne Merriman, Dr. Anne always inspired us to say, look, we need the people who have the fire in the belly, who have the zeal and the passion and the compassion to serve and to give more and above what is required. And looking at all these 23 volunteers coming through from Ireland, driving ambulances on their own expenses, they spent lots of money, I can tell you, and lots of commitment. We were in Uganda here. We have been groups together with Democratic Republic of Congo in the amplifying of the message about Ebola, as you may imagine. But this team decided to come all the way. Now, how do you quantify that in terms of money that has been raised for palliative care? So it's been about resources and money. Yes, I've given you an estimate and a figure. It's been about awareness. All our social media platforms as the association at the Ministry of Health have had stories and have had people feeling. We have attracted people whom we didn't think about. I mean, in discussing this, we've had phone calls from government people beyond Ministry of Health asking, what is it about? How come you are doing this? This looks very important. This looks very attractive. And so we've had to attract people. And then we have created hope. I can tell you, Jean, and the people who are on the call, that this kind of drive has been special in reaching out to people in the community. As the convoy came in and as we shared information on the social media, and people are on TikTok, on Instagram, people can look forward to something more that is coming. And for me, those three things have been very, very important in terms of this campaign. And I am grateful to everybody who has donated, everybody who is sharing the information, and every other volunteer from Ireland who joined the convoy to bring the ambulances to Uganda. I thank you so much, Jean.
Well, I have to say it got a lot of publicity in Ireland, so there was a lot of media done about it. And from my perspective, what I loved was it was allowing Ireland to see how much needed to be done in palliative care in Africa, and helped to raise the profile of that as an issue. So I think that's a very important. So I think on both in Uganda and in Ireland, it was a really good awareness raiser, as well as raising money. Come back to the money and the ambulances. How are you going to? We know you don't know an absolute figure yet, and there is a link for anybody who would like to contribute it in the chat. But tell us how you hope to use these ambulances and to spend this money to have impact in Uganda.
Yeah, thank you so much, Jean. So we have very nice and state-of-the-art vehicles that have been delivered to our country. In fact, in some of the districts, these will be the very first kinds of vehicles that they will have. We have decided with our partners, Hope on Wheels, and from the start that these will be mobile outreach clinics for palliative care services. These are not vehicles that we are thinking about to do health emergency work in terms of what ambulances do, because we feel strongly that the models of palliative care service delivery, the model of community outreach, increases the number of patients that each hospice can see tremendously in a month and in a year. And these models of community outreach, which include moving from a specialist palliative care team, will move from a hospice or a palliative care unit in a hospital and go to a designated health facility. And Jean, you will know that of the 300 health facilities in our country that offer palliative care, over 75% of these are government, and they never go out. They never go to the community. But you know that the majority of patients, especially those at end of life, will die at home. So they will be in the community. And so they will find so much trouble traveling from wherever they are, the long distances. Our country states 5-kilometer radius as the average, the minimum that somebody should travel. But this is never the case. This is like the ideal, not the reality. People travel long distances. You'll find a whole district of about 36 kilometers kind of radius and more, up to 50. Somebody has to walk or to move by whatever means to come to a center of palliative care just to correct oral liquid morphine or to get some pain relief or to do a consultation with their palliative care provider. So we want to challenge that with these ambulances. And these vehicles will be used by specialists to go out to the community. Now, once they reach at a lower health facility in the community, patients within the area can gather and get support and see the palliative care providers, see their doctor, do consultations, do medical refills, and then they can go back. Once we have the money, we are going to do grants. These grants are going to be prioritized for areas of need that we have as a country. And I know these are not unique for Uganda, but they're across. We have been doing a lot of good work with our partners through the Global Partners in Care, Center for Hospice Care. We've been offering scholarships for palliative care in our country, and as well as African Palliative Care Association has been offering scholarships. We hope this can be one of the things we add to, we contribute to, because we really have a small workforce when it comes to palliative care. Of the 3,000 people we need to offer palliative care at the Health Center 4, Health Center 3, at lower health facility, because we are doing our best to integrate palliative care into primary health care, we only have about 350. So when you talk about 350 versus 3,000 that you need in our country, we'll also be talking about and looking and emphasizing palliative care for children, Our country sees that as a big need, so this funding will go to that. We'll have palliative care for humanitarian situations. Uganda is one of the leading countries in our region and in the world which hosts more refugees, and they are integrated within community, but they have unique challenges. And we do not have special programs which are more palliative care for humanitarian settings. We have limited few of those. We want to see if we can do some work around that. And then we'll reach out areas that we have not really reached. And this has been our niche as PICAO, as an association, also with our partners. And we want to reach, we still have districts which don't have any palliative care providing health facility. And so we look at this fund as an opportunity to reach there. So those are some of the areas that I can talk about, but ultimately, we want to challenge the statistic that is really disturbing. Uganda is hailed as a model of palliative care service delivery in our country, in Africa, in the region, but we still see only 11% of the 500,000 patients that need palliative care in our communities. So that's where we want to put our money once we have all this raised, and we are grateful to all the contributors.
Mark, that was a masterful presentation of the needs for palliative care in Uganda. I'm very struck by that 350 health workers where you need 3,000 trained ones. And in fact, one of the things we're looking at is creating a series of webinars, every couple of months, and that the next one might be on that whole training need and how Ireland can help in relation to supporting that. So clearly this has been a very important fundraising initiative. It can't raise too much money for the needs you have in Uganda. So, but I must say, I have a certain amount of pride in Ireland for the fact that it took this initiative and that it has been so well received. I'm going to come back to you in a moment, Mark, to ask you about something else about Uganda and Africa. But first of all, I'm going to introduce our next contributor, who is Lacey Ahern, the Executive Director of Global Partners in Care, which is a US-based organization that has been doing phenomenal work in supporting access to hospice and palliative care in low-resource countries through developing collaborative partnerships and advancing research and education in palliative care. Global Partners in Care are a brilliant example of an organisation building partnerships, and they have 35 partnerships between US and African hospices or palliative care organisations, and that includes Mark's organisation, PICAO. In May last year, Global Partners in Care welcomed more than 30 palliative care leaders from around the world to Dublin for a workshop entitled Collaborating for Global Impact. The purpose of this two-day gathering, which I was privileged to join, was to consider the future of global palliative care, its current landscape, and the potential for action as a global community moving towards a common goal and vision. Several projects arose out of this workshop, one of which was to address the challenges of how palliative care is understood or perceived around the world. Before I get to Lacey, can I ask Mark to give us some context? Mark, when we met in Kampala in February, you said that misunderstanding and ignorance about the benefits of palliative care were one of the biggest barriers to increasing palliative care reach in Africa. Can you explain this a little bit more for us?
Yeah, so thank you so much. And I'm glad that we are on the same call with Lacey and everybody who is doing this work for us globally. One of the greatest challenges that we have had, and I can share this with a passion that I have, I've been leading the Palliative Care Association of Uganda Secretariat for some good years now. I moved from here, and maybe 60% of my time is to explain what palliative care is. Every time I step into an office, which is influential, where we need resources, where we need understanding, where we need influence to change a policy, a strategy, a practice, you start with, so what are you talking about? So we find ourselves every single day explaining ourselves what is palliative care. For those who have interfaced with the concept of palliative care, they sometimes put us all into end of life. And so you find that as soon as you appear and you say, I am the representing the Palliative Care Association of Uganda, oh yeah, you're the people who talk about death, and okay, today is not about death, today is about prevention, today is about care, NCDs. And so the notion of misconception, the notion of stigma, the notion of low understanding of the concept of palliative care in Africa and perhaps globally is indeed real. And I can summarize it by saying that palliative care is often equated to end-of-life care in our case, especially in Uganda. And in fact, some of the hospital, including hospital directors or people in positions of authority, they will say, look, before you go for palliative care, you need to do this and this before you end up in palliative care. So they create some stigma around it to say it's like at the end of everything, not integrated at the point of diagnosis, at the point of bereavement. And the stigma does not only stop at we who work in this space, but it also touches the attraction of those who should train, who should qualify, who should do the work. And therefore, we end up with limited number of people who are attracted to do this as a professional service because the funding is not really tagged to it because of this kind of understanding. The health workforce is not really enough. And even the training institutions, you can imagine, even Uganda, that is a model, the training institutions are still few. I can go on about this understanding and misunderstanding, but I can
think
stop there.
I think what you've done is given us a really good scene setting for Lacey to talk about the work that was done in Dublin and then since. So over to you, Lacey.
Thank you, Jean, and thank you, Mark, for that background. It is indeed helpful. I want to first just tell you a little bit about our partnership model as Global Partners in Care, because that sets the stage for where we went with the Collaborating for Global Impact initiative. We have been twinning hospice and palliative care organizations for more than 25 years. Jean mentioned we have 35 of these US-Africa partnerships. There are many of you on the call. I can't mention all of you. In addition to PACAO, many of our partner organizations are on this call. And this is all toward the goal of enhancing access. And we have worked very closely with APCA in this, and I want to mention that as much as we've worked at the grassroots, we have engaged with national associations and regional associations as key partners to ensure that all of these twinning partnerships really are feeding back up into larger awareness goals in the country. So we've really worked very closely with APCA. And although our work is not Irish-led, it is certainly Irish-involved, given all of our connections that you'll hear about on the call. Our model is simple. It takes time. We connect people and organizations, helping them build relationships and engagements that are meaningful and impactful. These relationships are built on foundations of trust and open communication, and every partnership is different. The Palliative Care Association of Uganda's partnership with their US organization is very different than Hospice Africa Uganda's partnership with their US partner. But really what we do is provide a framework, let the partners identify opportunities for synergy and collaboration. So we're bringing the seeds into the garden, we plant and nurture them as they grow, offering what each needs to thrive. And so this foundation is how we've always done our work. And we've been so inspired by what we've seen and learned from our partnerships, how the knowledge exchange, the shared learning, the friendships, and the meaningful programs that evolve are really making a difference for people and communities who have need for palliative care. So, we began thinking about our next 25 years as global partners in care and what we would do to increase our impact. And we asked ourselves, can we take the learning from these grassroots partnerships and and enhance that into larger collaborations that can bring impact on bridging these enormous gaps that we have globally in palliative care. And I'm going to quote an Irish writer here, James Joyce, who, in talking about his writing, he said, "I always write about Dublin because if I can get to the heart of Dublin, I can get to the heart of all cities in the world. In the particular is contained the universal." And that quote very much resonates with our work. We believe we have more in common than different as humans, as organizations, and with the challenges we're facing in palliative care. Mark talked about the awareness challenges, the misunderstandings, lack of understandings in Uganda. And working on a global scale, I can tell you that's common across so many countries and contexts. And so when we hear and we see the particular of what someone is doing in one country or context, we really believe that those can be shared and then adapted into our own specific cultures or context. So what we do is create the space for those partnerships and that sharing. And so I'll continue on, Jean,
Please
to
do.
talk
Please
about Dublin.
do.
Yeah, so really, you could say that Dublin is the origin story of the new GPIC and the forward direction for global partners in care, because this is where we launched our Collaborating for Global Impact initiative, which was an effort to bring together a group of palliative care leaders and supporters from across the globe to talk about our greatest challenges and strategic opportunities. But it wasn't just to talk, it was actually to challenge our thinking to be innovative, strategic, to disrupt the status quo of doing what we've always done and find opportunities to accelerate progress toward a shared vision of palliative care being accessible to all in need across the globe. And so at the Dublin workshop, as we lovingly call it, we work together as a team to co-create projects centered around strategic priorities. We used a human-centered design approach, which allowed us to elevate voices to really across levels of engagement, skills, professions, and to really sit together as equals and create something together. And one of these projects we called the Sicilies. And this was one of those concepts to strengthen a unified global voice for palliative care. And the idea was to use an award platform to showcase impactful communications campaigns that highlight the global message of reducing preventable suffering as a way to improve understanding and engagement with palliative care. So the idea was to really test whether a global communications award like the Oscars for, or the Tonys could really elevate high quality work in the field and generate meaningful learning about how palliative care is understood and communicated so that we could reach that goal of increasing awareness and understanding of palliative care. So this has been, we are right in the process of testing this concept right now. We have gathered feedback across different contexts, including at the APCA conference in Botswana last year. And earlier this year, we piloted this in Latin America at their regional palliative care conference. And we had a lot of great interest and engagement. So working with the conference partners, we had a call for submissions, we had a structured review process, and then we awarded this Palliative Care Communications Award at the conference in the closing of the conference. So we had great attendance there. And just a note to say that this was a very low input project. It was sort of a low risk, let's try this and see if it works. Let's get feedback, and then we'll iterate it to see if it makes sense to continue this idea moving forward. Jean, go ahead, please.
I think you've given us a great feel for it. And I think what was really interesting was just to elaborate what we did in Botswana, which was where a series of people who had been involved in Dublin or were interested in the project went and talked. So we each went and we talked to 3 different hospice operations in Africa over lunch, whatever, did questionnaires, did feedback. And what I loved was we were testing a concept of there being sort of shared communication, but also this whole idea about reduces preventable suffering and using it as a way of talking about palliative care instead of talking about end of life has, I have to say, been really a game changer. And I have found, I, for example, spoke at the award giving for one of the certificates in the Institute of Hospice and Palliative Care set up by Dr. Anne Merriman earlier in February. And I had written my speech using end of life care and I reworded it to talk about palliative care reducing preventable suffering. And I watched how it was landing. And I just thought that is such a great build on communication. And if we can share the learnings and share the materials. So you might tell us a little bit about the winner in Latin America because it's just such a lovely, different way of thinking.
Yes, absolutely. So the winner was a theater group, is a theater group from Sao Paulo, Brazil. That the goal of their campaign was to transform the understanding of palliative care through community-based interactive theater. The group is called Descoisando, and I think you have their Instagram in the chat. You can take a look at them. They utilize art education as a tool to transform how all individuals, not just healthcare professionals, think about palliative care. They have a vision in which health and well-being are promoted within the broader social and community context. And that rings true with the WHO and our goals in palliative care as well. Their application, just to tell you, started with this sentence: art touches hearts, so informing through feeling is our goal. Their campaign really stood out for its powerful use of art, dialogue, and education to deepen public understanding of palliative care, autonomy, and the reduction of preventable suffering. And the judging panel, which was a multidisciplinary panel from actually had Brazilian panelists, but also international panelists judging this, all thought it was just a very creative way to reach new audiences, to try and use different language to help people understand what palliative care is. So through the art, dialogue, and then public reflection. So their plan is after they do the play, there will be dialogue and conversation about this as well. They want to help individuals view dying differently, see palliative care differently, and make sure that dignity, autonomy, and humanity are at the center of it. So
it's a really exciting example, Lacey. Can we very briefly talk about plans for moving this forward?
yeah, so in Brazil, they are moving forward. I believe they're planning the play to be put on in a couple of months. We will be following that closely to see how it goes. We also recognize that it's really important to measure what we're doing and try and understand a little bit more the impact it's having. We've actually been having some conversations with the Irish Hospice Foundation to help us think about how we measure theater and art, the impact of that. And we are doing further testing around this language of reducing preventable suffering. We are in conversation with the Asia Pacific Palliative Care Network, who has an upcoming conference to do some kind of communications campaign there. So we think there's promise here. And again, it's at a stage where this is very low input, but we're just trying to bring ideas to the table and share those across contexts to see if this is something that we can use to help increase awareness and understanding of palliative care globally and in the particular contexts as well.
Lacey, thank you very much. I think it's wonderful to see these innovations, and I know you have other innovations. We've just chosen one of the outcomes of the Dublin meeting, but I know there's other things going on that we might get to talk about on another occasion. So our last innovation project is one that is very close to my heart. This is a pilot project for palliative care for elderly nuns in Africa. Dr. Eve from APCA is also very involved in this, as is Julie Ling of the World Health Organization, who many of you know. Our contributor today is Sister Jane Francis Nacafero, excuse me, Sister Jane Francis, who is CEO of St. Francis Hospital Nagalma and has just stepped down as Regional Superior of the Little Sisters of St. Francis in central Uganda. The Little Sisters of St. Francis have a very strong link to Ireland, having been founded by Arklow-born Mother Kevin Carney. Sister Jane Francis, tell us about the needs for palliative care for elderly African nuns.
Thank you very much, Jean, for giving me this opportunity. I want to begin by saying that we, the Catholic sisters or nuns, as some people call us, dedicate our lives to the service of God's people by offering education right from kindergarten up to university level. We get involved in the healthcare ministry, social ministry. And when I talk about social ministry, I'm looking at street children, I'm looking at abandoned babies, I'm looking at leprosy patients, etc. And then pastoral care. When we are doing all this, we have the energy, I tell you, and so are all over the place, actively attending to the well-being of our people. At times comes when we retire from this active ministry and our energy is spent. This is worsened by illness we might have acquired along the way, especially hypertension, diabetes, cancers, you name it. And it is at this very precious time that these elderly sisters you are seeing there need palliative care. Palliative care will ease their pain and discomfort. It will reduce their loneliness and stress. It will give them the highest quality of life and meaning of life. And this can only be done by addressing physical, emotional, and spiritual needs. Remember that palliative care can be available at any point in time, no matter what the prognosis or diagnosis is. So this is why I think there is a need for palliative care.
I think you make the case very well, Sister Jane Francis. This is a pilot project. So this is designed to build a model of palliative care that can be rolled out to sisters all across Africa, and it's estimated that there are 6,000 to 10,000 elderly African sisters in Africa who are in need of this care. Can you tell us what this pilot project involves?
Thank you. In summary, I may say that the pilot project involves developing a model of palliative care which can be rolled out to other religious communities in Uganda. To get to this level, we have to go through 6 objectives. The first objective is to identify the palliative care and comprehensive needs of older retired nuns. Objective number 2 will be to develop an adaptable, person-centered, and evidence-based model to meet the needs that we may have identified in objective number 1. Objective number 3 will be to train stakeholders, including health professionals and informal caregivers, to deliver the model of care. We go on to objective number 4, which will be to deliver the person-centered palliative care and healthcare needs, which will include essential medicines, and equipment as identified by WHO, that is World Health Organization. And then objective number 5 really will be to collect data and evidence of the effectiveness of what we shall have carried out above. And if all this is really effective, it is going to lead us to objective number 6, which will be to roll it out to other religious communities across Africa. I think this is what the pilot project involves.
If Dr. Eve was here with us today, as she was intended to, she would be talking about the importance of the measurement in this project. So this is a model, a scientific model of care that can be written about in any scientific journal. So it is actually measuring exactly what is going on with these sisters now, what the challenges are, what the quality of life and death is, and then it will measure at different stages. In the implementation phase, it will actually measure a series of things every month. So at the end of it, we will have what Dr. Eve keeps saying is gold. We will have proper measurement that allows us to support the rollout of this. And we were talking recently at a meeting about where this learning could go other than to the sisters and to religious communities. And we were being reminded of the number of communities for vulnerable children, vulnerable elderly people, which are being run by the sisters. So all the learnings out of this will impact on those sort of organisations, as well as impacting on places where sisters are working. So the model involves training formal and informal caregivers, which means you will have a lot of ripples out from this project.
That's right.
We'll talk about, I'm going to ask Sister Jane Francis about timing, just to say objective number 1 and number 2 are almost complete, with thanks to the very generous funding of an Irish philanthropist who gave us the funding for that. The funding for the training and the implementation have not been found yet, but there are a series of discussions and pitches and things going on, and we are very hopeful that we will get the funding in place. Sister Jane Francis, if we get the funding in place, what will the time scale look like?
Okay, first and foremost, I want to inform everybody that the timing plan is in 2 phases. Phase 1 is what is already going on, which is objective number 1, identifying the needs, and objective number 2 of developing the model. So we are already working on this, and we started in April, and we shall move on up to July. As Jean has said, funding is available, and actually the work is going on. Phase number 2 will encompass all the other objectives. However, we begin with objective number 3, which is of training. It will be massive training and sensitization. And if we get the funds, we would want to start this in September. So it will move on from September to December. And then as we get funding, we shall move out to other objectives. Thank you, Jean.
And this is going to be a very interesting partnership, because the rollout of this requires the involvement of a lot of different organizations, and we have already had meetings with the Vatican about it, and have meetings with a series of different stakeholders. So there is when I speak about it in Ireland, I get an enormous amount of support, because so many Irish people had grandaunts or relatives who were sisters who are out in Africa or who are priests. Personally, I have the strange situation that my grandmother was a doctor and a nun in Tanzania. So I grew up as a little child with my grandmother, a doctor and a nun in Tanzania. So that's one of the reasons why I'm so passionate about this, because I look at the conditions in which Sister Jane Francis's community is dying and other African nuns communities are dying. And I go, these could have been my grandmother's colleagues, and this is not fair. This is not just. Most of the European nuns and American nuns go back home to their own countries where they are well looked after. But we don't have that level of resources in convents in Africa, and that's what makes this this project so important. Sister Jane Francis, is there anything else you'd like to say about this?
Yeah, I would like just to add a little that in rolling out this information, we are going to partner with associations of the religious in different countries, because each country has a very good network, an association. So we shall approach them, but all this will depend on how successful we are going to be in rolling out this pilot project. Thank you.
Sister Jane Francis, thank you. And it's I know I'll be watching with great interest, but I'll be more than watching, I will be involved. But I'm sure a lot of people on the call will be very interested to see how this project goes.
Thank you.
We've had 4 very interesting contributions. We have a series of questions. We have 15 minutes for questions. Let me give you some of the questions that have come into through the chat. So, here is a question from David Hindoa Moses. Despite growing recognition of palliative care as a human right, implementation remains limited in many African countries. What do you believe is the single biggest obstacle to scaling palliative care, and what actions should governments, health professionals, and development partners prioritise to overcome it? Would you like to start on that one, Mark?
I think I'm still mute. Can you repeat the question?
We can hear you now. Yeah.
Oh, okay.
Did you hear the question?
Can you repeat the question?
So basically it's, what are the biggest barriers to developing palliative care in Africa, and what should governments, health professionals and development partners prioritise to overcome them?
So it's a very, I had the question well, but I just wanted to make sure that, it's a very broad question, and but let me group them into maybe 4 areas. And this is what you will find everywhere when we talk about the biggest barriers of palliative care in Africa. One of them is inadequate access to pain relief medicines. Obviously, look at everything else we're talking about. The access to pain relief medicines in Africa is not even a quarter of what it is elsewhere. We talk about severe workforce shortages. I already explained the low human resource that we need for palliative care. In Uganda right now, we have an opportunity that people can train to have a diploma, a bachelor's degree, and a master's degree in palliative care. But that's here. In the majority of the areas of Africa, you will not be able to get that training quickly, and people can come to Uganda and train. But still, the people are still so few. The human resource for palliative care is really still few. And then when you talk about systemic funding challenges, that should be on top. We have seen the funding for palliative care across Africa really, really small. And that affects everything. Now it will affect the appreciation, the attracting of the human resource, the access to medicines. And sometimes when you talk about supplies for palliative care, we forget the really big needs that happen for patients and families in the home. For example, somebody needs a colostomy bag, someone needs a clutch, someone needs a wheelchair. Those are things that look like sometimes not to be spoken about as health supplies and equipment, but these are really, really big things. We just spoke about together with Lacey about the limited knowledge, the stigma and cultural taboos that happen with us in Africa. It's not, it is a fact that in Africa we speak about death, grief, dying, and loss. Maybe not necessarily in the way that the Western world will speak about that at death cafes. We speak about it in terms of transition and information from the older persons to the young. But in the majority of cases, we delay diagnosis, we delay reporting to hospitals because we procrastinate, because of the challenges that are veiled. The poverty stops us, majority of the people, from seeking healthcare quickly. Out-of-pocket expenditure for healthcare is still so high in our country, it's 40%. So the challenge of poor health care, I can say, because if you look at how much is available to be spent on healthcare across Africa, it's really, in most countries, it will be less than 10% of the total budget of the GDP. So the challenges range from those, in summary, that I spoke about, and the poverty that faces people. So talk about limited knowledge, stigma, talk about cultural beliefs, talk about low funding, talk about severe workforce shortages, and then lack of access to medicines, if I can say that, and health supplies in homes and families. Those are really big challenges, and you can summarize them and share more about it. Thank you, Jean.
That's very helpful. Lacey, you're going to add to that.
Only a very brief statement to say that what can development partners or international global partners do to overcome these? The number one thing is listen to your local partners. Let them guide your actions, form these relationships, and really let your local partners guide the action. We can't make decisions from abroad.
Very, very wise words, Lacey. Trish, over to you.
Yes, well, what I wanted to say was I think one of the ways of improving access is what we've been doing, I think, from the beginning. But I do like that the definition of palliative care has changed, which is it's not end of life care. And I think just accepting that and making sure that that message is right across the medical services, because, you know, if you are providing good comprehensive care and 360, whether it's psychosocial, whether it's surgical, whatever it is, and you're making sure that that child has access to that, then that is good palliative care. And I think getting that message across, and I'm really glad that the palliative care community are pushing that as well, because, you know, we did, for a colleague of mine who is a palliative care specialist, did a questionnaire, and most of the people said they had no experience in palliative care. And I was like, no, but you do really good care for these patients and you follow them up. You are a palliative care specialist. Maybe not the subsection of end of life and all of that, but I think making that distinction, I think, is really important.
Thanks, Trish. I think one of the goals here in Ireland is that palliative care is no longer a specialist thing. It is something that is inherent in everything we do. And I know we've had discussions that Irish Aid should make sure that is embedded in all the projects that they are funding. But we've got a little bit of way to go on that one first. We have a question, Trish, while you were talking. We had a question about the palliative care navigator you have and the issue of GDPR. I know you answered it in the chat, but you might just answer the challenges of WhatsApp groups and how you handle them.
Yeah, sure. Our patient navigator is a very experienced. We were very lucky that she came from another organization, very experienced palliative care social worker. So we were so lucky to have her. And yeah, so for the WhatsApp community, if the child is registered in our system, then the parents sign consent for that. But a specialist or a doctor in any of the hospitals can ask a question about a child, and they can withhold, you know, the identifier, so the name or the hospital number. They just give us the age of the child and the story, and we don't ask for consent for that. So that's how we get around
that. Great. We have a question from Thilo Govender, which is, please comment on the use of language in palliative care in Africa and how we can make this better in a culturally sensitive way. Who would like to take that? Mark?
Yeah, and I think that's like a very good question. Lacey hinted on something very important about appreciating the needs from the perspective of those who are in Africa and appreciating the facts and the information that they need right from here. One of the things that has been very clear for us as the Palliative Care Association of Uganda, and that is our goal, the statement of our goal is to ensure the availability and accessibility of culturally appropriate palliative care in Uganda. And in the majority of cases, the palliative care that is appropriate in one area of the country is not necessarily appropriate in another area of the country. In Uganda, for example, you'll find that in some communities, it is the men that build homes, that do all the work at home. In some communities, it is the ladies, the women who are doing this kind of work. Now, generally, there are some acceptable ways and practices that you will find. In hospitals, the carers, the caregivers, a majority of them are women, are female in our case. Now, for you to be culturally appropriate means that you need to appreciate that kind of phenomenon in a home. As you are discussing with caregivers, who is going to be the one taking care of the patient practically? Who is going to have the hands-on care for the patient? Be it a child, be it an adult, be it a youth. Then who is going to make the decisions on paying for the costs of medical care? And that kind of patriarchal society, in our case, if you come to challenge it and to speak about things that may not really be in tandem with the culture, then it will not work. So I like the comment in the chat. Someone was really emphasizing, can we talk about comfort care? Can we talk about health, preventable health suffering? Can we talk about stories that show that indeed palliative care is not simply about end of life? Can we talk about things and needs of the people at the community, at the family, in the way that they experience and see them? Because palliative care is supposed to be more listening. So there is no universal answer to this question, but to go back to Lacey's point of, can we as palliative care providers, as donors and funders, and maybe Jean, that's why you can come in and also, I am sorry, I can ask a question as I conclude. What makes it so difficult for some of the donors to appreciate that they need to listen to the beneficiaries and the implementers on the ground? You have done this work for over and over, and it has been so apparent to you that you appreciate that you need to listen and co-create programs with Sister Jane Francis, Dr. Eve Namsang, and everybody. What makes it so difficult? And that's where sometimes we find challenges as implementers on the ground. But to really say that it's important that we offer palliative care that is culturally appropriate and sensitive, such that the myth and misconceptions do not continue to think, because in fact, some people think palliative care is something being imposed on hospitals and on people. We need to change that by being sensitive and agreeing that culture, and we miss sometimes about spirituality and spiritual care in palliative care. I'm looking forward to the results of the project that you are working out with nuns, and I think it will answer some of these questions on how we can integrate spirituality and care, because that's where we need to go. Thank you.
Thank you very much. Sister Jane Francis, you're running, you're CEO of a hospital there in Uganda with palliative care. The question was specifically about language and getting appropriate language in relation to palliative care. Have you thoughts on that? And I know you're a big palliative care advocate from your own personal experiences and from our conversations. So how important is language, and how do we get the thinking on that?
Language is extremely important, Jean. Our program started in 2015, and it has been very successful because we try to meet the needs on the cultural level. So even if we go with medical students who are visiting from the US or from Germany, wherever, there has to be an interpreter. And then this visitor doesn't mean that they can tell us, on what to do. Theirs is more of observership, because they are learning how we manage according to our culture. So language is extremely important, and not only language, how we do things in our culture, it is extremely important.
Yeah. Thank you, Sister Jane Francis. I think we have run out of time, and we promised we would get people finished in time. If I can thank my four brilliant contributors, Sister Jane Francis, Mark Muswego, Trish Scanlon, and Lacey Ahern. If I can also thank the Irish Global Health Network, particularly Cara and Ivana, and Joan as well, for all the support they have given in relation to this webinar. We hope these webinars will continue every couple of months. The next one might be on education and training, but we'd love your feedback as to what it is you would like to hear. And I think Mark, when he went through the barriers to palliative care there, really has given us some more food for thought. Can I thank all of you for joining us and spending time with us today, exploring issues around palliative care. And hopefully you're going with away with some inspiration or some hope. So thank you all very much, and have a good rest of the day. Oh, and do fill in the feedback forms that you're going to receive. Thank you very much. Bye.